I'd like to call the Special Committee on Long-Term Healthcare for February 13th, 2023 to order. Madam Clerk, would you please call the roll?
Alderwoman Davis. Alderwoman Boyd.
Present.
Alderwoman Middlebrook. Kathleen Holmes.
And for Alderwoman Middlebrook.
Okay. Kathleen Holmes. Harold Braswell.
Present.
Lenny Jones. Marjorie Moore. Laura Barrett.
I'm here.
Lavita Richardson. Victoria Nruri.
Present.
Andrew Lackey.
Here, present.
And Annalise Stover.
Present.
Danielle Spratley. Chris Beckley. Tasanya Johnson. Jamie Opsel. Cindy Jackson.
Here.
Ellen Usher.
Present.
Kevin Anthony.
Present.
Chair Ingracia.
Present.
Alderwoman Davis. Kathleen Holmes. Lenny Jones. Marjorie Moore.
Lenny Jones is here, sorry.
Lenny Jones is present. Marjorie Moore. Lavita Richardson. Danielle Spratley. Chris Beckley. Tasanya Johnson. Jamie Opsel.
Here.
We have 13 present. We have a quorum.
Thank you so much, Madam Clerk. Would you mind, I see Danielle Spradley, who's on the committee, is, I think she was having some difficulties logging on as a panelist. So could you move her from attendees over to panelist for me?
Yes.
Great, thank you. The first order of business we have is to approve the minutes from the Monday, January 30th and February 6th meetings. I would entertain a motion for that if you have had time to look over those minutes.
I move to accept the minutes.
Can I get a second?
Second.
All in favor signify by saying aye.
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 All opposed?
Aye.
All right, by your motion, you have sustained the minutes for January 3rd, 2023 and February 6th, 2023. The next item up for business are our guest speakers. We have Lisa Smith, the Missouri State Office of Long-Term Care Ombudsman, and then Shunda Whitfield with SCIU, also a nursing home worker. So Lisa, if you're ready to go, you have up to 10 minutes to testify, and then we'll do Q&A. And I just have to swear you in really quickly. Do you swear that the testimony you're about to give will be the whole truth and nothing but the truth? Great, thank you so much. So if you could just introduce yourself, your affiliation, let us know kind of briefly what you're going to cover. And then, like I said, you have up to 10 minutes, so take as much time as you need, and then we'll open it up to Q&A for the committee.
I'm sorry, Chair Ingracia, before she begins, Ms. Spradley, she's not in the attendee side at all. I'm not showing her on here at all.
I see her, Danielle Spradley from Representative Corey Bush's office.
Okay.
And it looks like Chris is also in the attendee section and not the panelist section.
Okay.
All right, Lisa, please proceed.
Thank you, and good afternoon, everyone. My name is Lisa Smith. I am the lead ombudsman and regional ombudsman coordinator for St. Louis City with VOICE, the long-term care ombudsman program in the St. Louis area. I'm going to talk a little bit about what I see when I go into nursing homes, really post-COVID, and a couple of the trends that I'm seeing, and just go over a little bit of my experiences when I go into these nursing homes. First of all, VOICE is a federal part of the Ombudsman program is part of a federal program that came out of the Older Americans Act back in the 70s. Every state has their own ombudsman program, and each one runs them just a little bit differently. For example, the ombudsman program in Illinois, in addition to the nursing homes, they also oversee home health care agencies. We in St. Louis and Missouri do not. We only oversee licensed nursing homes, both state and federally licensed. That includes residential care communities, assisted living communities, and skilled nursing. There's another level called intermediate care facilities, which we only have 1 or 2 here, but that also is a federally licensed long-term care entity. What do? We advocate for residents who live in long-term care communities. We empower them by educating them about resident rights. We are directed by them, so they have some autonomy as far as what we report or don't report to the staff or to our state organization. We respond and we try to resolve issues that come up with their care and improve their quality of care on a day-to-day basis. I've been in my role for over 5 years. I've overseen the city the whole time, so I have experience both pre, during, and post-COVID. And I am seeing certain grievances, we call them, complaints, that have been coming up in no particular order the last several months. Call light response, no surprise there. Most of my facilities, if not all, are short-staffed. And so that can result in a person sitting in a soiled brief for too long, which can then lead to skin breakdown, which when you're older and you have diabetes, your skin doesn't heal as well. That can result in a hospitalization, which, as we know, those are not always the best places for an elderly person to go, and can result in some very, very serious complications. Call light response can also be water out of reach. The resident can't reach their own water, and so they press the call light button to get that water, but the staffing shortage is such that either they don't have enough people, or the people they do have are very busy covering lots of residents, so they don't get to that person in time. Can be slipping out of a wheelchair that can result in a fall, and that can also result in a hospitalization, which can lead to further complications. Staff attitudes. Staffing is tough. We all know this, but sometimes the staff are either overwhelmed, overworked, or they're not the right fit. So that can result in some staff members ignoring residents. They sit at their nurse's station and they perhaps are overwhelmed, overworked. They're just there from agency, and so they're just there for a minute. They don't know the residents, so they don't have that that personal connection. And that can result in those residents feeling very intimidated and just isolated because they don't have anybody they feel that they can turn toward when they do need help. There has been quite a bit of personal property issues that have come up, whether it's their physical items or money that has been missing or lost or stolen, sometimes by other residents. Sometimes things truly are lost. But I have had reports from staff members telling me that some staff members do take some of the resident items. Specifically, there were some instances where the resident might die, and the staff members go in there and they kind of clean out that resident room and take what they can before it becomes official, and they have the authorities go in there. Again, that's an anecdote that I heard from another staff member. Medication errors. I had somebody tell me the other day just that they asked what medication they had in there, that they were being given, and it turns out that it was the wrong medication. There was a painkiller in there that the resident did not take. So there are errors. Medications are skipped. They can be late. Also, as we know, can result in some serious complications, especially for our more vulnerable residents. So a couple of those things that I touched upon, that staffing shortage, the staffing issues, use of agency staff, a couple of examples of problems that can result from that.
Okay.
I had a resident family member call me last week, and they said that their loved one had a significant weight loss and they were not notified. The regulation requires any change in status to be shared with the family member. That can be a mental status or a physical status, any change, good or bad. And the family member was not notified. So the resident ended up going to the hospital and was given a terminal cancer diagnosis. Now, was that a result of the lack of staff or agency staff that wasn't able to get to know that resident and know his or her patterns? We don't know. But the family member said this was a result of lack of information from the staff. Also, there was a resident I had that he has no teeth. So he needs his food cut up, or it has to be extremely soft. when there are shortages in staffing, typically you don't have the necessary dietary staff. So the trays might get delivered to the residents. They might even become unwrapped, but the food is not cut. So that resident was not able to cut his own food. He was not able to get the staff to cut his food due to a shortage. And he lost weight, he became weaker, and he ended up not getting out of bed at all, whereas he was getting out of bed a little bit, each day before that. So those staffing shortages can take a toll on our residents in lots of different ways. The other thing I'd like to talk about are our facilities, our aging facilities, and our lack of care for those facilities. I was in a facility a couple of months ago, and there were mouse droppings all over this resident's room, all over. Every surface was covered. And he told me that this has been this way for a while, that he could feel the mouse in his bed at night, that it was crawling in there, and I could see there were droppings everywhere. And this resident had bins. He had bins for his open food. His family members brought him 2 large bins to put his open food in. So they were trying. The family was helping. The resident knew what to do. When he asked the staff to help him, they put some duct tape over the hole that they felt the mouse was coming in. But of course, this was a facility-wide problem. It was just showing up in this resident's room. It did get resolved. It took about 2 months and a lot of phone calling and pestering, but it did end up getting resolved. And his room last time I visited was dropping-free and mouse-free. There was another facility of mine that the boiler burst and it broke. And so all the residents had to be moved in an emergency situation. And their pipes burst as well. And so the residents were forced to leave their community, in a couple of hours, which is very upsetting for a lot of the residents, especially those with cognitive decline, because they're used to their surroundings. So that was a challenge. One of my facilities had sewage dripping from the ceilings, and they were containing it in a large bin. You see the laundry in. There were sinks overflowing, the floors were flooding, and ceiling tiles dripping from the ceiling while the residents were using the toilet. A lot of these problems, these physical structural problems, are difficult to be repaired. I think the administrators often know what has to be done or what should be done, but there are barriers for them to get those repairs either approved, the funding for it, due to ownership changes, that sort of thing. So we're seeing a lot of barriers to getting some of these things resolved that we can't necessarily even address with the staff in the building, because there are those other entities that have to be gone through. A couple of the trends that I'm seeing, there is an increase of residents with mental health disorders in skilled nursing, and these residents tend to be quite a bit younger. I have a facility that my youngest resident was 21. 21 years old in a long-term care facility. He does have a mental health disorder. Likely in his life, he will go in and out of them. He will be there for a while. He'll leave AMA, or he'll leave because he's improved to a point. Perhaps he's going to become homeless. He'll go back. Typically it's going to be a cycle, but these younger residents mixed in with the traditional geriatric residents are a difficult population to manage. It's difficult for both sides, for the geriatric folks who want their sort of peace and quiet in kind of a, that's what we think of. And the younger residents who maybe they have some untreated bipolar disorder, but physically they're just fine. And so they might, go out more and come back after having had some alcohol or maybe they have a substance abuse issue. So they might come back high, and then they are disruptive to those older residents. I just had a call from an administrator last week that a very young resident who was agitating a lot of other residents about the smoking policy. Well, smoking policy comes from many different areas. It's not just the administrator who determines or decides what that policy will be. There are regulations, there's life safety code, there are assessments that have to be done. It's not as simple as yes or no, but the younger resident was stirring up trouble with the older residents, who then were all becoming, agitated that they weren't getting to smoke in their rooms and things like that. They didn't have that particular problem at that facility before this younger resident. Sometimes the younger residents, they can exploit the older residents. Can I have some money? Can I have some of your food? You don't need that? Can I have it? That sort of thing. And a lot of the residents might look at those folks like their grandkids, and so or they don't even know. So there's difficulty trying to manage both of those populations at very different, extremes of age. But we're seeing a lot of that happening, and especially in the skilled nursing. Skilled nursing is the highest level of care. So if you have a mentally, a resident with a mental illness that's untreated, typically he or she is going to be just fine physically. They don't need the nursing care. They really just need that medication oversight. But that is kind of a gap in our long-term care options at this point.
Lisa,
Yes.
you're a few minutes over time. Are you
Okay.
at a good point to wrap up and then we can do Q&A?
I would say, no, we're good for Q&A.
Okay, members of the committee, if you would just raise your hand if you have questions for Lisa, and I'll call on you as you request. Reverend Anthony?
Yes, I have a series of questions. The first one is, have you visited or spent time at, I think it's Northview, Hillside, and Beauvais, 3 of the nursing homes that are a focus in our conversations? Two,
Yeah.
the second one is, since you shared some information about staffing issues, how would you define or shape for us the accountability of the owners? What is their role in this? And not only that, do you have recommendations that you would offer in terms of holding owners who are negligent in spaces like this to do better by the residents and the people that work in those facilities?
So first of all, Northview Village, Beauvais Manor, and Hillside Manor Rehab and Healthcare. Yes, I have a volunteer at Northview Village. She's been there for 20 years, and she goes every week and she chips away at some of those problems. In fact, I'm meeting her out there next week. Beauvais Manor, I just placed a volunteer there last week. And the hope of these volunteers is that we're getting eyes on there more frequent, on those facilities more frequently. So we're hoping that our visibility can help improve, even incrementally, some of those chronic problems that we're seeing. Hillside Manor, I feel like that's probably the place I go the most, since COVID. I'm out there at a minimum 4 times a year. I'm out there more likely 10 times a year. I mean, I feel like I go every 6 to 8 weeks at a minimum, just following up on complaints or checking in with my, some of the residents. It helps for us to be there, depending on the administrator, depending on the social worker, depending on the problem. So we do, I am visible out there. I do have some residents that I'm able to communicate with by email, that sort of thing, that keep me up to date. The ownership is a problem, and I don't really have an answer for you, because the particular owners for Hillside and for Beauvais, they're in New Jersey, and their name is Luxor. They're a storefront in New Jersey. And so I know that I've met some of their regional folks as I've done my visits at Beauvais and Hillside. And I do get some good, I've had some success working with the regional folks. And so that might be the place to start, is working with the people who are here in the St. Louis region. And then, talking to them about the problems, and then kind of like, going further up the chain, just like we do in other things, trying to get eventually to the ownership. Ideally, the state will hold the owners accountable for some of these things, because, as I mentioned, the administrators are often, their hands are tied as far as how much they can do, given the lack of resources that they have access to, or they just don't have the permission of the ownership to make certain repairs, that sort of thing. I hope that answered your question.
Great. Laura, you're up next.
Thank you.
Those are great questions, Reverend Anthony. One thing I noticed when you were speaking is about the increase in mental illness and younger folks. Do you have sort of like a time range on that, and like when did you start to notice those increases? And then do you see any examples of places where people are actually doing things right, so that that would be helpful to understand? And then I just also wondered what the difference is between for-profit and nonprofit owners that you're noticing.
Yes. So, oh my gosh, I forgot your first question already. What was the first question?
Yeah, let's just for the committee, if we could ask one question at a time, that way we make sure Lisa's able to keep track of what we need her to report on.
Feel free to just do the profit versus nonprofit. That'd be great.
So, my only example of that one in my personal, oh, you were also asking about mental illness and then the time frame. So let me answer that one. I've been doing this for over 5 years. And in my tenure, I have seen the increase happen. It used to be when I oversaw Jefferson County, I thought, oh boy, there's some younger people out here. I thought it was more just because it's a little bit more rural. And then so over the last 5 years, I've seen that increase where it's noticeable to all of us in all of our regions, all of our territories, and we oversee 21 counties. The for-profit versus nonprofit, the for-profit, St. Louis Altenheim used to be a nonprofit, and it had a board. It had a board that it answered to, and then that money would go back into the facility. From my understanding, there's a certain percentage of profit that can be removed, and the rest has to go back into the facility in this case, in any nonprofit. And the for-profit, there's no determination to what happens to the money they make. They can allocate it as they wish. There's no restriction on Medicaid dollars that X% has to go toward food, X% has to go toward resident care, X% has to go toward anything. So they're able to put as much or as little into these facilities as they choose. There's no oversight other than their own ownership.
Great, thank you so much. Ellen, you're up next, and then Andrew.
Okay, I'm a little bit under the weather, so apologize. You just have my picture. I had a question, and I think I need to talk about my background just a little bit. My mother was in a nursing home, and all of the issues that you described, the trends, were very much prevalent, and that was 5 years ago when I took her out in 2018. And I'm pretty well versed in the law, and I am an attorney, and I did go to the ombudsman, and then we would go to the administrators, and then we would report to state, and they would come in, and things would be okay for like maybe a month, and then we would have the same issues. So my question is there any way that the state can hold these facilities more accountable? I know last week we had someone speaking about, losing their license, but is there any way that we can try to push the state to be more proactive with these conditions?
So that's a really, really good question. And I don't know the answer to that. I have had recently a couple of administrators tell me they wish the state would be tougher on them. They're self-reporting. They're reporting a problem by choice to the state in order to, be very transparent. The state comes in, and then the things they're reporting are unsubstantiated. So there's a frustration with that whole process as well, and partly that's because the surveyors, there aren't enough of them. There aren't enough of the surveyors to go in as much as they need to. Part of it is the regulations can be ambiguous depending on your viewpoint. And one could argue some different things. If you look at those regulations, they're 850 pages of guidance for the surveyors to look through in order to enforce those regulations. So that's difficult too. And the turnover, not only at the direct care level, but at the department head level. I mean, I feel like I am starting over every couple months with some of these complaints that I have and some of these chronic issues because there's a brand new administrator. And so I have to, you have to start over with them and tell them the problems and here's what I'm trying to resolve. So it's with the lack of consistency at the department head level, it is very difficult to have a consistent level of good care. So I think there's no one answer. They're all connected. It's staffing, it's money, it's oversight of the owners, it's more surveyors who can have more power to get in there more frequently. It's really the systems are broken, in my opinion. And so it's very difficult. That's what we try to just chip away at it bits at a time where we can and bring attention to some of the other things, which I think if we, nationally, we're seeing some of the same attention being brought. And so we're hopeful that starting with staffing, if there are staffing minimums put on there rather than whatever the nursing home feels is sufficient, that might help, because when you have more staff, typically you will have better care, and then those things, will all snowball.
Thank you, Lisa. Andrew, you're up.
So, my follow, I have sort of a follow-up question to Reverend Anthony, and that is that we've heard some on this committee about not just the fact that we have outside for-profit owners, but also we have kind of this middle level of sort of management companies that then that the owners will then hire to manage the nursing home. So so has that how has that impacted your communications with trying to get things resolved between the managers, which might be separate but hired by the owners?
So I haven't directly had experience with that outside managing agency. I typically have the administrator who is hired by, let's use Luxor. Luxor hires the administrator. The administrator, even if they leave without a new administrator coming in, then Luxor uses their regional folks. So I really haven't had an outside managing company that I'm aware of come in. I've always had the administrators and the social workers, the DONs, who are directly hired by the owners. And then I just will go to them with my concerns, complaints, and then if they are unwilling to help me, then my role typically does stop and it goes up to the state.
Thank you.
Great. Let's do 2 more questions before we move on to our next speaker. Lenny, I think you were up, and then Jamie, you're next.
Great. Thank you, Alderwoman. I really appreciate this presentation, Lisa. And can you describe a little bit more about what it takes to become an ombudsman volunteer? Because I think it sounds like that's a really important role to develop, that then somebody who has the capacity to be there on a weekly basis, or as long as it takes, often as it takes. Thank you.
Yeah, the volunteer role is huge, and they go through the same training that we go through as ombudsman staff. There are 36 hours of training put out by ACL, the Administration for Community Living, so it's standardized across the country. There are 10 hours of shadowing done with either experienced volunteers or ROCs. We're called ROCs, Regional Ombudsman Coordinators. There are 5 of us in my office. So there are usually 4 shadow opportunities sprinkled in this 36-hour training. And then after that, the volunteer will be assigned to a nursing home. Typically, we try to have them in an area where they are close to home, because it makes it easier to go to those places, because they typically will go once a week, anywhere from 2 to 4 hours. And they do what we do, but on the volunteer basis. So we have about 30 volunteers right now who go into nursing homes all over our regions. And we're also seeing younger folks coming in who want to do this. The gentleman I just placed at Beauvais Manor is 30. So that's really good too. I think it's nice to have a diverse population of volunteers as well as the population that we're serving.
So, hi, Lisa, thank you. I have a question for you. How is the Department of Mental Health engaged in this issue? Since they are based on the Missouri Constitution, they are responsible for treating and preventing and addressing mental health and substance abuse disorders in the state of Missouri. And I know that as mental health facilities have closed across the country back 20 years ago, the work was supposed to be transitioned into community mental health centers. But what we're seeing is that people are still being, we're seeing an increase in people with mental health disorders living now in nursing homes, like you were saying. how is the Department of Mental Health, what's their role in this, and how are they addressing these issues?
So I don't work with the Department of Mental Health, so I don't know what programs they might have. I do know that some of my lower level of care, my residential care facilities, are often dual licensed with DHSS, Missouri State, as well as DMH. So they have extra support provided to those residents because of that dual license. I do know a couple of my facilities that were residential care dual licensed to have chosen to go only DMH. And so they aren't even becoming part of long-term care anymore. They just want to work with the Department of Mental Health. So that might be a trend that's coming as this problem becomes more visible and more of a problem really to some of these skilled nursing who don't know what to do with these folks. Department of Mental Health, I know that some of my facility administrators have reached out to get some at least some ideas, some guidance of how to work with that population, but I don't know of any actual changes that are coming through DMH in order to address this part of the population that is not being served correctly.
Thank you.
And then one last thing I want to say, I remember Laura's other question, who's doing it right? Really doing it right just means to be accountable. When something happens, acknowledge it, address it. If you can't fix it, then tell me. If your hands are tied because of, tell me, tell the resident, tell the family member. People are reasonable. They just don't like to be ignored. So I always tell my residents when I visit them, I say, nothing will be perfect. We know that. You live with 100 other people, but is it as good as it can be? And so the places that do it well, they show interest. They will, follow up with the resident. When there's a grievance presented to them, whether by me or internally, they at least take the time to tell the resident, I acknowledge what you're saying. Here's why I can't change it. Regulation. It's a safety code. You can't smoke in your room because it's a danger to your roommate. Something, but just address it. So there's effort being put forth rather than just an automatic dismissal that resident or family member or my concern is just noise. So there are places who do that. And I have administrators who I enjoy working with because I know they're going to be responsive. I know they're going to at least try to help me help this resident. So I would say that is the sign of a good place. Nothing's perfect. Everyone's short-staffed. Food is tough, those sorts of things. But when you acknowledge somebody and you treat them with that kind of respect, just to let them know, I'm not ignoring you. I just can't fix this because give them a reason and then you just try to do better.
That's really helpful. I do have two quick follow-up questions. You had mentioned having some conversations with regional contacts for Luxor. Do you feel comfortable possibly sharing those contact people, maybe name and an email address for me? We've been trying to reach Luxor themselves and in New Jersey, and I don't know that we're going to have any success.
So I have two that I can think of. And so, and one of them I just spoke with last week. So I would have no problem asking her if I can share that and share that with you guys. So I will follow up with both of those and just give them a heads up that I would like to do that. Make sure.
Yeah, okay, that would be great if you could check. And then do you think that there's any value and if there is there a expedient way to order or request records from the facilities that are in the city of St. Louis? Do you think there's value in us reviewing those, or
what kind of records?
The records, I guess, for the information that you're gathering on complaints. I'm assuming that there's going to be some records from the surveyors from the state. I'm just curious if those are items that you think would be helpful for us to review.
What I would do is I would start with one facility and see if you get the records and see if there's value there rather than going further. A lot of the information is on the DHSS site, the Show Me Long-Term Care. If you dig in there a little bit, it'll show you what the survey showed. It will show you what the complaint visit showed. It shows you plan of correction. There is some good information on that site. Again, you have to click a few times to get to that. Their survey, their annual survey binder is available to the public, or so any of us could go in there and ask to see their survey, and so we'd be able to see what's in there. The problem is you're not going to see those complaints that, don't go through the state. You're not going to see the ones that come through us or come through other avenues, internal grievance procedures and that sort of thing. So it'll give you a picture. It just won't give you the whole picture. And I would, reaching out to Mike Ponder's office to understand the process for that. He's the regional manager for DHSS in St. Louis. DRL, the Division of Regulation and Licensure. He would be a good one to guide you on how to do that. And if there's additional information that's not available already on that DHSS Show Me long-term care site, that would be the question I would ask him. Is there additional information you might be able to have access to that can't be found already on the public site?
Okay, will do. Thank you. And to Sonia, if you wouldn't mind popping your question or comment in the chat, I would appreciate it. I want to make sure that we give Shunda Whitfield time to testify and do Q&A as well. And Lisa, if you wouldn't mind just hanging on for just a minute in case Tasani needs to address you. And thank you so very much for taking some time out of your schedule to come and testify before us.
You're welcome. Thank you, everyone, very much.
Shunda, are you ready to go?
Yes, ma'am, I am. Can you hear me?
Yes. Do you affirm that the testimony you are about to give is the whole truth and nothing but the truth?
Yes, I do.
Okay. If you could just state your name again for the record, let us know your affiliation and where you work, and then you have up to 10 minutes to testify, and then we'll do Q&A.
Okay. Hello, my name is Shonda Whitfield. I work at the State of Spanish Lake. I'm also affiliated with SEIU. I'm a part of the COPE committee. What I'm about to tell you, I'm quite sure everybody on the phone probably have heard about the elephants that need to be addressed in this room. The nursing homes systems are failing. I've been in this field for 30 years, and I have seen a lot of transitioning. They are failing the residents getting the adequate care that they need. They are failing the workers who are sacrificing everything, getting nothing back. For-profits, out-of-state hedge fund owners, and ripping off the nursing home systems and buying whatever they think they want, I guess, instead of paying workers and taking decent care of these residents. The whole darn system needs to be torn down and made over. We need a better system from the ground up. It just needs to start over. But while we are waiting for a nonprofit system that prioritizes care, the government needs to start enforcing, going after these owners. I mean, like really going after the owners of the regulations of the nursing homes. These owners need to be fined and penalized today for the way that they are treating the residents there, as well as their workers. They don't even, we be out, we be sick. They don't even have decent common-sense to call us and say, are we okay? The NLRB needs to bear down on unfair labor practices complaints. Somebody needs to do something. The St. Louis City Health Department and the State Department of Health and Senior Services needs to get bed bugs out of nursing homes. We know that they are recently been into 2 homes in the St. Louis City, both Northview and Hillside. Both buildings are distressed and needs maintenance badly. At Hillside, sewage is coming up in the sinks in residents' room. Both these older buildings are going to need enforcement. The St. Louis nursing home owners have been acting like they don't have to obey a fair bargaining, collective bargaining agreement with their own employees that come in here faithfully, come to work faithfully. I mean, the ones that's on their staff that comes to work faithfully. We're not talking about the agency people or things of that nature. We're talking about their own staff members that comes there faithfully to see about the residents. It is thrown out the window is the residents and the workers who suffering. We are being exposed to the sewer that we have to go and see about these residents. Sewage can give you, toxic, bagging up sewer. I mean, it can make you really sick. Workers need training in infection control. I have right now, for the second time, COVID again, all over. I know workers and residents who had as many as 3 times. For us, the pandemic is not over because we're still working up under the conditions, and we still trying to see about our residents that have became our family. Some of them don't even have family, so we are their family. We're struggling with long COVID, consistently fragile lung and heart issues, and more. I have lupus, so I take a chance every day when I go to work to see about our extended family. We need training and infection control for every nursing home worker, whether they are in the laundry or passing meds to help stop the spread of this pandemic. Housekeepers, dietary aides, anybody that deals with the residents. I know this committee has heard this nursing homes. The nursing homes are also handling 4 more people with mental illness. In the nursing home where I work, it's about 85% of residents who has mental health now. I've been there almost 10 years. And the transitioning within the last 2 years has been detrimental. It really has. We have a very few of our workers who are working consistently with the residents have been trained in and how to handle and de-escalate folks with mental health issues. We have asked our management for CPI training, which is the gold standard. It's the basic standard to help us diffuse situations. We're not receiving it. Unfortunately, last week, one of the fellow workers was attacked by a resident. She is traumatized and made a police report. What happened to her is unacceptable. We need to fix this broken system. To summarize, the long-term system care is broken. We may take a long and hard look at the problems and come up with solutions. I am very excited that the Board of Aldermen to agree to start this committee on a long-term care. I'm looking forward to report you will release after you are finished with your hearing. We are doing everything that we can, and the truth out there. And we appreciate everything you can do to help us in these situations because it's really, really detrimental. Every day, when we used to go to work, at times we used to be able to know what we're going to work to do. Now it's like so unbalanced and so unsteady. We don't know if we're gonna be breaking up fights all day, or we gonna get punched in the face or attacked by somebody, or just getting somebody off another resident. It's just things just constantly just going on and on and on and on. Some of us are truly therefore our residents. We love our resident. It's not about the money because they really don't pay us what it's worth. It's about we became family with the people that we take care of every single day. So they look forward to seeing us. They look forward when we come to work. They look forward, to talk to us and try to make things better for them. So it's just been a really terrible transitioning these last 2 years. And I just think something has to be done for the mixture. I know everybody needs somewhere to go. Don't get me wrong, I really understand that part. But I just think the mixture has came and just kind of like overpowered the whole structure of long-term care. Thank you.
Linda, thank you so much for taking time to fill us in. This is obviously incredibly troubling information that you've passed along. And I think having testimony directly from somebody who is on the ground doing this work every day has such value to us here. I'd like to open it up to the committee. If anybody has questions for Shonda. Go ahead, Harold.
Hi. Well, thanks so much for your testimony, first and foremost. That was really powerful and a very important perspective. So I guess one question I have in terms of I think in terms of what I'm hearing, what we could do maybe to help the situation in what you said, it's okay, maybe regulations for owners to have more reasonable staffing patterns, better wages, provide more training, particularly with dealing with the new resident population that you're talking about. Could you, what other sense do you have of what might help that we might be able to do based on what you're seeing in the ground?
Well, I just think that people, of different calibers need to be think more visible. Is that a correct answer to say more visible? I think, just like the ombudsman lady said, Miss Lisa, yes, she goes out there from time to time or certain many times or when people call. I think that's a wonderful idea that they have put volunteers in certain places, but I just think that it should be more visible, to hold them accountable, because when you go out the door, it's out the door. If you understand what I'm saying, I think that it should be something more set in stone, like, hey, you got this many days, XYZ, but during those days that you're expecting them to fix it, I think that they should drop by in between those days while they're supposed to be fixing it. Because I just think that it goes in one ear and it falls on a deaf ear, so I see you today, but tomorrow is back the same.
Thank you, Shonda. Chris, did you have a question?
Not really a question, just a comment. I just want to make sure we're careful about discerning between the mental health issues that we're seeing in our nursing homes and those older adults who are struggling with dementia. I think the comment was 85%. I just wondering if that's mental health related issues combined with those with dementia for our older adults. So I admit the mental health issues are very much an issue, but I just want us to be careful about possibly putting everybody in the same category as dementia and mental health.
Yeah, that's a great point. I appreciate you bringing it up. I'm assuming statistics are kept on that somewhere. And if so, do you think that they're being kept appropriately and being tracked the right way? Go ahead, Laura. Go ahead, Chris. I'm sorry, Chris, and then
no,
Laura.
that's a good point. I don't know, but I think with placement of those struggling who may be younger with mental health, it's a bad combination, no doubt. But to Jamie's point, I'm not sure where else they could go. It's certainly not good for the programming we put in place for those older adults who are at different levels of dementia, and it can create a more confusing environment for them, making it harder for us to implement those programs so that they can thrive the best they can.
Go ahead, Laura.
I was just going to say some of those statistics are in that briefing paper that we shared with the committee. And those statistics were that 40% of the folks who are within the city of St. Louis nursing homes, according to CMS data, which is the Center for Medicaid and Medicare Services, 40% of folks had severe mental illness diagnoses of schizophrenia, bipolar disorder, and other disorders. So that was the rise in the amount of diagnoses, and then there was a drop off in terms of the average age of folks in the facility. But I think you better bring up a good point, Mr. Beckley, as well, that it is kind of two areas there.
Great, thanks, Laura. Does anyone have a question for Shonda?
I have a question and a comment. Shonda, what you are talking about, and people need to be very clear, because I worked in the industry for 50 years. And so this isn't new. This started happening before COVID. COVID just exposed it more. But the nursing home industry has started, I want to say, I remember when we were, the certified dietary managers was pushing legislation to make sure everybody that was a manager in dietary was certified. So, I mean, they had to go to school, they had to get tested to become certified. Because, as Shonda said, they were just hiring anybody, people that had no knowledge of nutrition, health, diets, they didn't know anything. So they were pretty much like not equal, but they were complementary to the dietitian. So they could help the dietitian in those facilities, because a lot of those facilities didn't hire dietitians, they only contracted out. That I worked at, and they had numerous buildings, and I kept saying, you bringing in younger people, they have mental issues, and you're mixing them with senior. The young people don't want to play bingo. That's not what they're trying to do. You need to have a building for those young people. And I even told the owners, have one building, and that's all you will have in that building is young people. Then the mental illness, I think that's something that the mental health and the nursing home owners should be working in conjunction with each other, because as somebody said earlier, they don't know where they're sending these people. Well, they closed all the mental health places down. And so I told the owners, I said, you need to have a building just for people under 50 years old. And then you need to have a place just for mental illness, because you're putting the staff at danger. So when our ombudsman would come, we would have team meetings with the residents and the ombudsman for them to kind of talk about what the issues were. And then we start addressing them. And Lisa is right. If you ignore those residents, they're going to raise all kind of HE double hockey stick. But if you listen to them and try to work with them, they understand, okay, it's 50 people before me. And so I got to try to figure out how I'm going to do this. But when you have people that's in the nursing homes and they have tons of UTIs, and you go to them and say, well, why do you keep getting UTIs? Because I don't want to bother the CNA, because I don't want to drink the water, because then I have to go to the bathroom. And so that's abuse to me. That's like having an animal and you put the water across the room and you chain them up and they can't get the water. So I agree with Shonda. It needs to be down to the bare minimum and start rebuilding the nursing home industry, because the owners are in it for the dollars. And so the first thing is, if you don't take care of the employees, and I tell people that all the time, if you don't take care of your employees not going to take care of you. I'm not for the $15. I think they need to get $25 an hour. Because if nowhere in the world I can pick up a resident, that's dead weight. So look what you're doing to these women's bodies. So, and men too. So, I mean, I just hope this committee, Alderwoman Degrassi, will start looking at breaking it down to the bare minimum and start taking layers to address issues. So at least we can see that we're making a difference, because it's just too many things at one time to try to say we're going to fix it all. But we need to look at the number one priority and then just start breaking it down like that. I mean, it's just a suggestion, that's all. But Shonda, I understand what you're dealing with. And, I was accused of I cared too much. Because if somebody said they wanted neck bones and potatoes, I would go buy the neck bones, potatoes, cook the storm, cook the greens, the hot water cornbread, and give it to them. They say, you doing too much. Well, my
Mhm.
philosophy was, if this is the last stop they make before we put them in the ground, I give them whatever they want. So
Yes, Lord.
that's just my thought. So
Yes, Lord.
I'm sorry, I don't mean to ramble, but you all are really touching on a very sticky subject here, and I just have a problem with this. So I'm just letting you know.
No worries, Alderwoman. I appreciate your comments, and I think coming up with some priorities and our recommendations is definitely the goal of this committee. So I think that's the exact work we'll be undertaking once we hear from all the speakers and start to be able to dive into the reporting back to the board after this. We have just literally 3 minutes left. So Annalise, if you could go quickly, and then Tasanya, you're up next, and then we'll adjourn.
Yeah, I just wanted to make the comment that, you know, I have had relatives in nursing homes that I visited for years. It's very true that people that are not visited, that are not seen, receive worse care. And so with that in mind, you know, I really would suggest that one of our priorities be getting out information about residents' rights, because each resident in a nursing home has a list of rights of, you know, that should be adhered to. And then also trying to expand the volunteer programs and get people into the nursing homes so that people can see what is happening and also can help out just visiting and putting more eyes on people in need.
Great, thanks, Annalise. I think that's super helpful to help guide us moving forward. And then Tasanya, did you want to add something, or did you have a question?
Just real quick, I wanted to add, I know recently I have met with a couple of the ladies at SEIU, and there was communication around, you know, providing more training and support to the union members themselves in the facilities as well. And I think that's a very good thing to do in collaboration with the facility, because as much as we can talk about, you know, what's going wrong, or, you know, the owners not doing or doing, I do think that a core part of the problem is, you know, from the staff. And a lot of it is, you know, developing them more, because you want to pull out of them, what's their purpose for being here? You know, what are we doing for the residents? And if we can all come together, not just in the facility as the administrators, the owners, but those other support layers, even from the state, you know, pulling resources and training as much as we can pour into the staff as possible to show them that, yes, you are supporting them, but also get back to the core reason as to why we are doing it. There has been a lot of, you know, care and compassion that has left the industry. And it's not just since COVID, but it has been, you know, pre-COVID, but we do need to keep that in focus when, you know, trying to get around to fixing what we're dealing with in the industry as a whole. But I think that's something that would be definitely helpful. I know a couple of you all have spoke on here that are from facilities that have the unions. So if we can connect together and pour into the staff to help support them, that definitely will help, you know, provide better care and services to our residents.
Yeah, thank you so much for that insight. I really appreciate it. And we are going to adjourn. Next week is President's Day, so we don't have a meeting, but we'll be back here on February 27th at 3 p.m. Thanks to the committee members, and especially thanks to the speakers we had today. See you all in 2 weeks. We're adjourned.